Imagine waking up one morning and feeling like something is just off in your ear.
Right, like a sudden sense of fullness.
Exactly, a fullness that definitely wasn't there yesterday. So
Yeah.
go to the mirror, you shine your phone's flashlight in there and you see it.
Oh boy.
Yeah, it's this soft, pale, pink mass just sitting right in your ear canal.
And it's mobile too.
It is, it moves, and if you accidentally brush it with a cotton swab, it immediately starts bleeding, and worse, it's accompanied by this thick, blood-tinged discharge that just has incredibly foul odor.
I mean, that immediately triggers a visceral reaction, right? You see something like that and your brain just screams that something is fundamentally wrong
Yeah.
in a place that you really can't reach.
It sounds exactly like the setup to a medical thriller, but this is actually a very real, highly specific clinical presentation. So welcome to today's deep dive, where we are going to look into this fascinating scenario.
I'm really looking forward to this one.
Me too. So in the medical community, this specific scenario, a bleeding oral polyp with suspected cholesteatomatous chronic otitis media, it earns a much shorter but heavily loaded nickname. They call it the unsafe ear.
Unsafe ear. Yeah, it sounds ominous because it is.
Right. Treating it is, it's essentially like diffusing a biological bomb. You make one wrong move in the initial assessment, and the patient could literally wake up permanently deaf or paralyzed.
The stakes here are just astronomical because the entire clinical roadmap we were examining today revolves around navigating this incredible labyrinth of delicate anatomy.
Because it's all in the temporal bone, right?
Exactly. The temporal bone houses not just your hearing mechanisms, but the primary facial nerves and direct pathways right to the brain. So the presence of that bleeding polyp is basically a blaring siren that something disruptive is happening deep within that labyrinth.
So for today's mission, we're looking at a case of a young female patient presenting with these exact symptoms, and the clinical clues are heavily localized. She has the bleeding polyp, the foul-smelling discharge, and profound conductive hearing loss.
Right, which they confirmed with tuning fork tests.
Yeah, the tuning fork test confirmed the mechanical failure. So she has a negative RIN test on the right, meaning bone conduction is now greater than air conduction. And the Weber test lateralizes directly to that right ear, so the sound conducting apparatus is blocked.
But there's a really crucial detail in her initial exam.
Right, she does not have facial nerve palsy, and there are no cerebellar signs. Her balance and her cranial nerves are, for the moment at least, totally intact.
And honestly, that absence of neurological symptoms is like the only deep breath the clinicians get to take here.
Yeah.
But looking at the diagnosis of an unsafe ear, we have to recognize that the polyp itself is actually a distraction.
Wait, a distraction?
Yeah, it's just inflammatory tissue. The real threat, the actual monster in the room, is adipointrontal disease. It's this relentless, hidden pathology in the upper and posterior chambers of the middle ear and the mastoid bone.
It's kind of like the classic hidden leak in a house, right? You see a dark water stain spreading across your living room ceiling. You don't just spackle over the drywall.
No, absolutely.
You have to assume there's catastrophic rot in the plumbing or the structural beams behind that ceiling, which brings us to the absolute golden rule printed at the foundation of this entire clinical pathway.
And it's a strict rule.
It really is. Always suspect cholesteatoma in a bleeding oral polyp, and never, under any circumstances, remove a polyp blindly in the outpatient clinic.
Right? Because if you see a mass, the human instinct is to biopsy or to pull it out. But a cholesteatoma is a really unique entity. Despite having that illness suffix, it is not a tumor.
Right, it's not cancer.
Exactly. It is a trapped, expanding sac of squamous epithelium, basically skin cells growing,
Yeah.
where they absolutely do not belong deep in the middle ear.
Which is wild.
It is. And these skin cells constantly shed keratin, which accumulates and becomes this perfect breeding ground for bacteria.
And as it grows, it just destroys everything in its path. But I think what's hard to grasp is, how does a pocket of skin manage to eat through solid bone?
It's a great question. The pathophysiology is fascinating and honestly brutal.
Yeah.
The cholesteatoma creates a localized pressure effect, sure, but more importantly, the chronic inflammation triggers this massive enzymatic cascade.
Like a chemical attack.
Pretty much. It activates osteoclasts, which are the body's own bone-resorbing cells, and it releases collagenases and other little enzymes. It literally dissolves the surrounding bone. So the polyp you see in the ear canal is just a sentinel with inflammatory granulation tissue
Right.
that is physically tethered to that expanding destructive sac.
Which explains the absolute prohibition on pulling it. If that polyp is tethered to the incredibly fragile ossicles, the tiny hearing bones, or if the cholesteatoma has eroded the bony canal of the facial nerve and wrapped around the nerve itself.
Yeah, that's the nightmare scenario.
Right. Grabbing that polyp with forceps and pulling means you are literally ripping out the hearing apparatus or tearing the facial nerve.
You pull the polyp, and half the patient's face droops instantly and permanently.
Wow.
Yeah. So the clinician's first job isn't removal, it's securing the scene and gaining visibility. They have to methodically clear the superficial debris to actually understand the geometry of the threat.
So that requires immediate, highly localized evaluation. The pathway dictates starting with an oral toilet using microsuction under a microscope.
Right.
So they are carefully vacuuming away the purulent discharge and the blood to define the exact origin point of the polyp. Usually, they're looking to see if it's descending from the upper space of the middle ear,
And they're actively hunting for something specific too.
the cholesteatoma flakes.
Exactly, those distinct pearly white keratin debris particles.
Now, microscopes are brilliant for depth perception and direct line of sight work, but the middle ear is full of hidden alcoves.
Extremely complex geometry in there.
Yeah, so that's why the pathway immediately introduces endoscopic evaluation. Using 0-degree and 30-degree angled endoscopes allows the clinician to basically look around corners.
Right, they can visualize hidden retraction pockets, peer into the sinus tympani, and map those anterior epitympanic spaces. The technology dictates the strategy here, ensuring no microscopic extension of the disease is missed before surgical planning even begins.
But I'm looking at the microbiological investigation protocol here, and I'm a bit hung up on the timing.
Okay, we do.
Well, they take an oral swab of the discharge and send it off for a culture and sensitivity test. But if this destructive mass is actively dissolving bone toward the brain, taking several days to grow a bacterial culture feels dangerously slow. Why pause to optimize the patient when there is a ticking clock? Doesn't this just delay the inevitable surgery?
I get why you think that. It seems totally counterintuitive to wait. But operating a highly infected, hypervascular field is a surgeon's absolute nightmare.
Because of the bleeding.
Yes, the inflammation makes the tissue bleed at the slightest touch, which instantly obscures the microscopic surgical field. You are operating literally millimeters from the brain and major blood vessels. You need pristine visibility.
So it's about altering the surgical environment before you even make an incision.
Precisely. The swab identifies the specific pathogens driving the acute infection. Most commonly, you're looking at aggressive bacteria like Pseudomonas aeruginosa or Staphylococcus aureus.
The bad ones.
Yeah, the ones that often form resistant biofilms. By identifying the exact bacteria, clinicians can deploy targeted, systemic preoperative antibiotics along with topical drops.
So they cool the whole area down.
Exactly. You calm the sepsis, drastically reduce the mucosal inflammation, and shrink the vascularity of the tissue. When the surgeon finally goes in, the field is manageable, and the risk of disseminating the infection into the bloodstream during surgery drops dramatically.
Okay, that makes perfect sense. Now, while those cultures are incubating, the pathway requires quantifying the collateral damage already done to the hearing apparatus.
Right, the audiology checks.
Yeah, pure tone audiometry and tympanometry provide the baseline. And the audiology graph in the source material highlights a significant air bone gap, which confirms the profound conductive hearing loss we noted earlier from the tuning forks.
And for anyone wondering, the audiogram separates the performance of the inner ear, the cochlea, and the nerve, which is tested via bone conduction, from the performance of the entire mechanical system, tested via air conduction.
Right.
So when the bone conduction is normal, but the air conduction drops significantly, it plots out as a physical gap on the chart.
It's pure physics. The sound waves hit a physical blockade, the cholesteatoma and the fluid, and simply cannot vibrate the ossicles. And documenting this baseline is critical because it manages patient expectations.
Yeah, that's a huge part of it.
The primary goal of the upcoming surgery is to make the ear safe, not necessarily to restore perfect hearing. If they have to remove eroded hearing bones to clear the disease, the hearing might not improve.
It could even worsen.
Wow. Okay, so once the infection is suppressed and the functional deficit is measured, the clinicians are still technically blind to the most dangerous part of the disease, right? The bone erosion hidden beneath the tissue.
Yeah, they need a map.
To map the true extent of the destruction, they require a structural blueprint. And the absolute gold standard of imaging for this pathway is the high-resolution computed tomography scan, the HRCT, of the temporal bone.
The gold standard for sure.
Going back to the house renovation analogy, this is the X-ray vision required before taking a sledgehammer to the walls. You need to know which load-bearing beams are compromised and exactly where the electrical wiring runs. And the pathway lists 8 distinct radiological findings the surgeons are hunting for on these scans.
And the HRCT is non-negotiable because it literally defines the surgical boundaries. They are primarily looking for scutum erosion.
What's the scutum?
The scutum is a sharp, bony spur that forms the lateral wall of the tympanum. If the CT shows that sharp point is blunted or missing, it confirms a deep attic retraction pocket where the cholesteatoma likely originated.
Ah, okay. They are also scrutinizing the vesicular chain. They look for erosion in the malleus, the stapes, and particularly the incus, which is notorious for losing its blood supply and dissolving under the enzymatic assault of the cholesteatoma.
It's usually the first to go.
Right. And they check for mastoidopacification, looking to see if the honeycomb-like air cells in the bone behind the ear are clouded with soft tissue and trapped fluid.
And all of this structural intelligence feeds directly into the most critical surgical decision of the whole process.
CWU versus CWD, canal wall up or canal wall down mastoidectomy.
Exactly.
And the anatomical difference between those two approaches is massive.
It really dictates the patient's anatomical future. If the HRCT shows the disease is relatively contained, the surgeon can perform a canal wall-up procedure, which preserves the posterior bony wall of the ear canal.
So it keeps things somewhat normal.
Yeah, this maintains the normal anatomy and mechanics of the ear. But if the scan reveals widespread, deeply invasive disease that cannot be safely exteriorized, they must pivot to a canal wall-down procedure.
Which means
they literally drill away the back wall of the ear canal, merging the mastoid cavity and the ear canal into one large open bowl.
oh wow, so it's all just one space.
Exactly. It ensures the disease is completely eradicated and allows for easy inspection in the clinic forever, but it permanently alters the anatomy and requires lifelong maintenance.
Now, the HRCT is phenomenal for viewing bone, but it has blind spots, doesn't it?
Oh, definitely.
It utilizes ionizing radiation, and more importantly, it struggles with soft tissue differentiation. Like, if the mastoid cavity is completely opaque on the CT, the scan cannot differentiate between the dangerous cholesteatoma, an innocent pocket of trapped fluid, or heavily inflamed granulation tissue.
Which is exactly when the pathway escalates to advanced magnetic resonance imaging, specifically an MRI with diffusion-weighted imaging or DWI.
DWI, right.
Yeah, DWI tracks the microscopic movement of water molecules within tissues. Now, cholesteatomas are incredibly dense collections of keratinized squamous cells. They physically restrict the diffusion of water.
So how does that show up?
On a DWI scan, a cholesteatoma lights up brilliantly white, clearly distinguishing it from surrounding fluid or just granulation tissue.
That's incredibly useful.
It's an indispensable tool, especially in recurrent cases where surgeons are trying to find microscopic pearls of disease hiding behind thick surgical scar tissue from previous operations.
And the MRI is also the definitive tool when clinicians suspect the disease is breaching the borders of the ear, which brings us to the geographic mapping of complications, and this thoroughly justifies why this is called an unsafe ear.
It's scary stuff.
An infection sitting in the middle ear and mastoid is occupying some of the highest rent, most perilous real estate in the human body. The complications branch out in 3 distinct directions, starting with intratemporal spread, meaning the disease remains within the temporal bone itself.
Right, and remember, the temporal bone houses the facial nerve inside the fallopian canal. If the cholesteatoma erodes that thin bony canal, the infection directly attacks the nerve, leading to facial paralysis.
And that's just the start.
Yeah, intratemporal spread also includes labyrinthitis. The disease can erode the dense bone capsule surrounding the semicircular canals of the inner ear. If the infection breaches the inner ear, the patient suffers violent, incapacitating vertigo and total irreversible sensorineural hearing loss.
As terrifying as that is, the disease doesn't always stay inside the bone. The second pathway is extratemporal spread. The infection physically breaks out of the skull and tracks downward.
Gravity and anatomy really conspire against the patient here. The mastoid tip, the bone you feel just behind your earlobe, serves as the attachment point for the sternocleidomastoid muscle of the neck.
Okay.
If the cholesteatoma and the associated pus erode the medial aspect of the mastoid tip, the infection bursts out and follows the fascial planes deep into the neck.
And this creates what's called a Bezold's abscess, which is a massive, deep-seated pocket of pus hidden under the thick neck muscles. It's wild to think a localized ear infection can manifest as a life-threatening swelling tracking all the way down toward the collarbone.
It really is wild.
But the third direction is the most lethal, intracranial complications. The disease moves upward and inward, invading the brain cavity.
The anatomical barrier here is shocking when you actually view it on the HRCT. The clinicians are specifically looking for tegmen erosion.
A tegmen?
Yeah, the tegmen tympani and tegmen mastoideum form a continuous plate of bone that acts as the ceiling of the middle ear and mastoid, and it is paper thin.
It is literally the only physical floor separating the infected, rotting ear cavity from the temporal lobe of the brain.
Just a millimeter of bone. If the cholesteatoma dissolves that barrier, the infection has direct access to the central nervous system.
And that's when things go really bad.
Unbelievably bad. This leads to extradural abscesses, meningitis, subdural empyemas, and literal brain abscesses. It can also cause lateral sinus thrombosis, where the infection triggers a massive blood clot in the sigmoid sinus, which is the primary vein draining blood from the brain.
That geographic breakdown really explains why the initial neurological assessment, checking the cranial nerves, monitoring for balance issues, looking for signs of meningitis like neck stiffness, it isn't just a formality. It is a mandatory continuous surveillance protocol.
Absolutely.
This clinical pathway isn't merely about saving a parent's hearing. It is a meticulously designed protocol to prevent a lethal brain complication.
And while the focus on that immediate threat is intense, modern medicine requires a systemic approach. You can clear the mastoid, you can reconstruct the hearing bones and seal the ear, but if you do not understand why the cholesteatoma formed in the first place, the patient is doomed to repeat the cycle.
The disease will just return.
Right.
That systemic approach is outlined beautifully in the adjunct evaluation phase of the pathway. The patient undergoes a diagnostic nasal endoscopy.
No, this always surprises people.
I mean, yeah. To a layperson, passing a camera through the nasal passages to treat an ear infection seems completely disconnected. But the nose and the middle ear share a vital physical piece of plumbing, the eustachian tube.
Exactly. The middle ear is essentially a closed, air-filled box. The only way it ventilates and equalizes pressure is through the eustachian tube, which opens in the nasopharynx at the very back of the nose.
Right.
So if a patient has chronic underlying conditions, like severe allergic rhinitis, chronic sinusitis, or especially in younger patients, massive adenoid hypertrophy, that nasal inflammation physically blocks the eustachian tube opening.
The plumbing gets clogged, and the mechanics of the ear basically turn against the patient. If the tube is blocked, the mucosa inside the middle ear gradually absorbs the trapped air,
And that creates a powerful negative pressure.
like a physical vacuum inside the skull.
Yeah. And that vacuum relentlessly pulls inward on the tympanic membrane, the eardrum. Over time, the weakest part of the eardrum, a highly flaccid area called the pars flaccida, gets sucked deep into the middle ear spaces, creating a retraction pocket.
And that pocket traps the shedding skin cells, and boom, the cholesteatoma is born.
So mechanical chain reaction.
Yeah, right. So if the surgeon performs a brilliant 6-hour mastoidectomy, clearing every microscopic cell of disease from the ear, but ignores the massive inflamed adenoids blocking the nasal plumbing.
The vacuum simply reforms.
Wow.
Yeah, the newly reconstructed eardrum gets pulled back in, and recurrent cholesteatoma begins eating the bone all over again. Identifying and surgically treating those nasal pathologies during or before the ear surgery is what transforms a temporary fix into a permanent cure. You absolutely must restore the physiological ventilation.
So with the disease map, the complications ruled out, and the systemic triggers identified, the pathway moves into the final phase, the preoperative workup. The definitive management plan is inherently dual-natured. Medical therapy to control the acute infection, followed by comprehensive surgical eradication.
Right.
But prolonged microscopic surgery near the brainstem requires intense physiological resilience from the patient.
The systemic baseline must be flawless. They run complete blood count and erythrocyte sedimentation rates to track the resolving inflammation. They check blood sugar levels too.
Because of wound healing.
Exactly. Uncontrolled glucose impairs wound healing and invites secondary infections. Liver and renal function panels are also checked to ensure the patient can metabolize and clear the complex anesthetic drugs.
They also run highly specific coagulation profiles like PTINR. You mentioned earlier how hypervascular the inflamed ear tissue becomes.
It's a blood mess.
Right, so if a patient has an undiagnosed clotting disorder, a microscopic procedure can turn into a hemorrhagic crisis that obscures the surgical field and endangers the patient's life.
And because these surgeries often last several hours, cardiovascular endurance is paramount.
So they do an ECG.
Yeah, the pathway mandates an ECG. And for patients over 40 or those with clinical history, a 2D echocardiogram. The anesthesia fitness check is rigorous. The anesthesiologist performs an airway assessment and assigns an ASA physical status classification to quantify the overall perioperative risk. Operating on the skull base is uniquely demanding on the cardiovascular and respiratory systems.
And wrapping around all of this clinical data is the imperative of informed consent. The clinician has to sit down with the patient and translate everything we've just discussed into plain language.
Which is not an easy conversation.
No, the patient has to understand that they might wake up with altered anatomy from a canal wall down procedure, that their hearing might not be fully restored, and that they face rare but real risks to their facial nerve imbalance. The entire physiological and legal net is cast to catch every variable before the first incision is made.
It represents the absolute pinnacle of systematic clinical logic. Nothing is left to intuition. Every single test, swab, and scan informs the next maneuver, constructing a holistic, basically unassailable picture of the patient's condition.
It is an incredible journey through a microscopic war zone.
Yeah.
So to synthesize this pathway, the clinicians achieve 5 distinct critical goals. First, they confirm the diagnosis without provoking the disease.
Yep, no blind pulling.
Exactly. Second, they assess the true extent of the structural damage using high-resolution and diffusion-weighted imaging. Third, they actively hunt for and intercept lethal complications extending toward the neck and brain.
Crucials.
Fourth, they use this intelligence to plan the exact surgical approach necessary to eradicate the disease. And fifth, they guarantee the long-term outcome by identifying and correcting the systemic plumbing issues that triggered the pathology.
It perfectly bridges the gap between treating a localized symptom and curing a systemic physiological failure.
So before we wrap up today's deep dive, take a moment to consider just how deeply physically interconnected your own anatomy truly is. We tend to view our bodies in isolated compartments, but think about the mechanical chain reaction we just explored. A subtle allergy or an enlarged adenoid blocking a tube in the back of your nose creates a silent, invisible vacuum inside your ear.
It's wild to think about.
It really is. Over months or years, that negative pressure physically pulls a microscopic pocket of skin out of place. That tiny pocket of skin aggressively alters its environment, weaponizes enzymes, relentlessly dissolves solid skull bone, and eventually threatens the brain itself.
Yeah.
It is a stark, almost frightening reminder of the delicate, complex architectural balance inside our own heads and the brilliant, meticulous logic medical professionals use to map it, manage it, and ultimately restore it when it all goes wrong.
I'll tell you one thing. It fundamentally changes how you perceive the simple act of swallowing to pop your ears.
It truly does. Thanks for joining us as we unpack the anatomy and the incredible clinical mapping of the unsafe ear. Until next time, keep exploring the hidden pathways of the world and the biology around you.